Kelly Linden here, and I'm going to present a lecture out of order. So, the lecture 24, and just the first half of lecture 24 in this audio. So, it will be muscle and exercise in health and disease, and the condition that we'll be looking at is spinal injuries. So lecture 24 will be split just into two audios, so it's a little bit more manageable to download at home. And this is being recorded at the beginning of week 13 because of the public holiday that's going to throw us out a little bit. Now, I've selected lecture 24 to record because it's sort of the shortest of the lectures. So I thought it's the one that you'll sort of miss the least from having in class for the internal students, and also a benefit for the distance students. Now, reading, there's on eReserve you can find some ACSM resources for clinical exercise physiology, and there's a chapter on spinal injuries, but most of the information that you'd need can be found in these lecture notes. Right, so this is the first time I'll be presenting these four lecture objectives, but these lecture objectives you'll see for every lecture for the rest of semester, and your section C, your long answer exam question in the end of session exam will be you'll be able to select from one of about 7 small case studies where you just get someone's gender, age, and any particular conditions, and you'll need to answer some questions very similar to these objectives. So if you were to select the special population that was had a spinal cord injury, you would be expected to answer, briefly describe the pathophysiology of spinal injuries. How does exercise improve the health of people with spinal injuries? What type of exercise prescription is likely to benefit spinal injuries and why? And in this section, it's likely that you'll need to write a short program for somebody to give and be able to justify the decisions you've made to create that program. And then finally, what are the risks of exercise specifically for this special population? And in this instance, it's obviously spinal injuries. Okay, now spinal cord injury is acquired after birth by trauma by trauma or to disease of the spinal cord. Now, it results in impairment or loss of motor and or sensory function in the trunk or extremities, depending on what type of cord injury and at what level. All right, the resulting compression, contusion, or severance of the spinal cord, depending again on the cause of the trauma or disease, or associated spinal arteries, results in spinal cord necrosis, so death of the spinal nerves, and which will then result in dysfunction. So, of the spinal injuries, approximately 45% are what we'd call complete, with total loss of sensory motor and autonomic function. So, what we can think of as input and output. So, spinal nerves running towards the central nervous system and away. There's complete severance or a loss of function below the injury level. Now, when this occurs, we use the word plegia. So you might have paraplegia or tetraplegia, depending on at what level that plegia has occurred. All right, but more than half, so approximately 55% of spinal injuries are actually what we call incomplete, with only partial loss. And in this instances, we call them paresis. So we might have tetraparesis or paraparesis. So there'll be still some spinal nerves that have survived the area of damage. Okay, so we can have a little bit of an overview, a look here at an overview. Hopefully it should be revision for most people of different levels of the spinal cord, and just a little summary of the function at each level. So we can see if there's an injury at or above C8, we call it tetraplegia if there's complete severance at that level, or tetraparesis if there's only some loss but some function still from lower down the spinal cord. So depending on at which level, say if the injury was at C3, well, let's pick a more realistic level here. At C6, say, you'd still have use of some wrist extensors, deltoids, biceps, diaphragm, so you'll be able to breathe, and movement of head and neck. However, if we're thinking upper extremity, you wouldn't have full use of your triceps or your hand, and then or anything below that level. If we look further down, say if the injury was at T7, you should have use of your upper limbs and then many of your chest muscles, but you will not have, or you'd have very limited use of abdominal muscles and leg, and further down. So it's important to have just a bit of an understanding of the different levels and what muscles they control, because if you were to select in the end of session exam as a case study, spinal cord injury, you'd be told at what level the injury has occurred, so you'd need to be able to then come up with some exercises that person would still be able to perform. Okay, now in addition to the spinal injury, there are a number of secondary conditions that may further compromise health of the person. Now, chronic pain can be a massive issue, pressure sores, depression, obesity, and poor cardiovascular fitness that comes purely through the detraining effects of the new sort of more sedentary lifestyle. Now, all of these can be improved with if you can perform more some kind of level of activity. It depends on the level of the spinal cord, how much activity can actually be performed. But there is a really real importance in remaining active following a spinal injury. All right, now exercise can be difficult in someone who's had a spinal injury due to reduced ability to perform large muscle group exercises. So that's a really, really important point. Ah, it looks like we've got a couple of people joining the lecture. We have Rosie and Tilly. Does anyone have any questions so far? Tilly, that's a silly question. Rosie, what's the importance of being able to contract large muscle groups? That's a really, really good point, Rosie. Smart, good dog. Now, if somebody can't contract large muscle groups, then it's going to be much more difficult for them to have any of the sort of the cardiovascular effects from exercise training, because we're not going to have enough muscle groups contracted, so that we're not going to increase blood flow enough, and we're not going to increase venous return enough to have many of the cardiovascular effects we'd like to have. We're also just thinking about on a smaller scale, we're not generating enough force to use enough, for example, extra calories that have been stored. So we're not going to burn as much energy with exercise as well. So it makes it quite tricky, and again, it depends on the level of the spinal injury. But if you can't perform large muscle group exercises, seeing the effects from exercise training that we've learnt about in healthy people become quite tricky. All right, puppy dogs, it's not time to go. Now, another reason exercise can be difficult is due to an inability to stimulate the autonomic and cardiovascular systems. So catecholamine production by the adrenal, can only be produced by the adrenal medulla in injuries above the mid-thoracic spine, because remember, the cardio-accelerator nerves through the sympathetic nervous system actually exit the spinal cord in the mid-thoracic. So if you've got a higher level spinal cord injury, the only way we can increase heart rate is through catecholamine production through the adrenal medulla, and the adrenaline and noradrenaline will go into the blood, bind to the sinoatrial node, increase heart rate. Now, this takes minutes instead of milliseconds to occur. We see less effect from skeletal muscle venous pump, and we can also have some thermoregulation issues in response to this, so poorer thermoregulation. Now, tetraplegia, so a high-level spinal injury, usually results in a sedentary lifestyle with profound deconditioning, because we're not actually contracting muscle fibers. If we're not contracting muscle fibers, then they're going to atrophy. Now, the primary neuromuscular effect is paralysis of the lower extremity, precluding exercises such as walking, running, and voluntary cycling. So all of the exercises would kind of think to prescribe to somebody of the same age and gender and situation without a spinal injury are usually not going to be possible. So we just need to be a little bit more creative. If it's a higher level spinal injury, you can often still perform an arm crank ergometry, so ACE, and in some instances, if there's if it's quite a high level injury, then you can even strap the person's hands onto um, the arm crank ergometer, and just perform some level of contraction. Wheelchair propulsion or wheelchair can be a really good way of keeping quite fit. And then ambulation with crutches is in some instances also popular, and again is quite physical. Now, exercise training can result in high upper body fitness levels, especially if the spinal injury is below the cervical level, so and especially if it's a little bit lower in the thoracic region. So during maximal work test in elite wheelchair athletes, average heart rate can reach 184 beats per minute. So still contracting a lot of muscles at a high rate. And VO2 max was 40 mils per kilogram, which is quite unbelievable considering they're not using the muscle bulks in their legs. So that would equate to a very, very high VO2 max if they were able to use their legs as well. They're quite fit. Now, activities of daily living are insufficient for developing physical fitness in most instances. So it's important to still undergo some level of exercise program, despite there might be some difficulties in activities of daily living. You might still get tired from them, but it's still really important to undergo some level of exercise training. Now, propulsion of a manual wheelchair up a hill or crutch walking are equivalent to moderate intensity exercise and can improve fitness levels. Now, arm exercise training adaptations appear to be primarily peripheral. Then we're not seeing the big central adaptations that we'd see if we're able to contract larger muscle groups. So at the periphery, at the arm, we see increased muscular strength, which is really, really important. Reduces the chance of overuse injuries as well. Aerobic adaptations to the muscle. So if we consider some of those adaptations that are not so central, but they're occurring at the muscle fiber, so we'll see increased nitric oxide synthase in the arterioles at the muscle fiber. We'll then see increased number of capillaries at the skeletal muscle fibers within the arm, the trained arm. We'll then also see increased myoglobin stores. We'll see increased size of mitochondria and increased number of oxidative enzymes. So they're all sort of the peripheral adaptations that are occurring at the muscle. And these will result in an increased VO2 peak. So we might not see the central adaptations that we'd see in somebody who without a spinal cord injury. So we wouldn't see the same dilation effects of the ventricles of the heart or the physiological left ventricular hypertrophy, because we're just not dealing with high enough blood volumes returning because we're just using small muscle groups. But we'd still see an increase in VO2 peak because we're going to see increased oxygen consumption. Now, because of the diverse functional presentations of people with spinal injuries and varying fitness goals, there are no general guidelines. But as a minimum, people with some arm mobility should aim for 30 minutes of aerobic exercise 3 times a week at a moderate intensity, so an RPE of about 3 to 10. Again, this is a minimum, so if someone was completely sedentary, you'd have to work them slowly up to this minimum, but you wouldn't just stop there. You'd really try and increase the duration and the frequency as fitness develops. Now, resistance training of upper body in some instances can be performed. Again, it depends what the level of spinal injury is, but you can use things like dumbbells, wrist weights, body weight resistance as well. And you might consider starting with one set of 15 repetitions 2 times a week. And then consider increasing the weight before you increase the repetitions or the frequency of the sessions. But following the universal training principles is necessary for achieving training outcomes. And we spoke about that way back in week 5 in lecture 12, so week 4 even. So remember, they were specificity, overload, progression, initial values into individual variability, and reversibility. So we'd want to consider all of these factors when writing an exercise program for somebody with a spinal injury. Um, Now, the risks, the final lecture objective, addressing the final lecture objective for spinal injuries is risks of exercise with spinal injuries. Exercise should be performed in an environmentally controlled and thermoneutral or cool gym due to, in many instances, people with spinal injuries have poor thermoregulation. Hypotension can be a problem, so dizziness should be monitored closely. Uh, Autonomic dysreflexia can sometimes occur due to dysregulation of the autonomic nervous system. We can also see upper extremity overuse syndrome. If you have somebody who is in a wheelchair and their activities of daily living are performed in a wheelchair, where poor ergonomics can be an issue, and then they start training in their wheelchair, then you can start to see overuse syndrome. So it's really important to monitor sort of limb or joint health, I could say. Uh, just as a summary, so spinal cord injuries are acquired after birth and result in variable degrees of motor and sensory impairment in the trunk and extremities. Exercise does not improve the spinal cord injury, but can often offset secondary conditions that would otherwise compromise health, such as obesity and cardiovascular disease. A combination of upper body aerobic and resistance exercises have been shown to improve health outcomes as well as improve quality of life. All right, great, thanks. Bye bye.